I am Dr. Sharjeel and you are watching my YouTube channel. If you like my videos, don't forget to subscribe my channel at the end. Now today I am showing you complicated cataract surgery. You can see this patient have pinpoint pupil with 360-degree posterior synechs, and we were unable to dilate him with pharmacologically. So now I have made a main port, the phaco 2.75 knife, and put viscoelastic, and now with the help of a dialer I am trying to remove the posterior synechs, and I will see whether after removing the synecchi the adhesions between pupillary margins with itself as well as with the anterior lens, that then the pupil become dilated or not. Now you can see I have removed a lot of posterior synechs, and the pupil is dilating, and you can see these dark rope like bands which I have removed from the pupil, and pupil has been a bit dilated, not much, but so very gently you should try to remove all the posterior synechs. And now the pupil has been little bit dilated from before. Now we have dislodged, removed all the posterior synechs, but still pupil is not much dilated, and phacoemulsification will be difficult in this complicated cataract due to iridocyclitis. So I have decided to place iris hooks. Now we have got 5 set of iris hooks or iris retractors. Now you can use all 5 or 4. I will use all 5. So in this video you will also see how to dilate the pupil, constricted pupil, with iris hooks. How to place iris hooks: you make 5 small ports with the 15-degree phaco knife, and then that's how. Now here I am engaging the iris in the iris retractors, in the iris hooks, but you can also take another very important work from these iris hooks, which later I will show, because as I told you that it's a complicated cataract surgery, not a routine cataract. So in these anterior capsule is also very resistant to Capsulorhexis, and the cortical sheets and cortical lens matter is adherent to the capsule, and when you try to aspirate it, the granules, they also get affected. So that's how we have placed iris hooks, and now pupil is sufficiently dilated to perform Capsulorhexis and phacoemulsification. So I have placed air, and now the blue dye to stain the anterior capsule. In a complicated cataract surgery you should place a dye so that Capsulorhexis will be easily visible. And in a uveitic complicated cataract, you should start pre-op topical as well as systemic oral steroids at least for 1 to 2 weeks, and also aggressive steroid therapy post-op for 2 to 3 weeks, because there is intense inflammation in these eyes post-op, and you have, and that can limit your post-op outcome. So you can see that we are performing Capsulorhexis. A round Capsulorhexis has been performed successfully, and now I am performing hydrodissection. Hydrodissection is a very important step in these complicated uveitic cataracts, because as I told you before that the cortex is inseparable from the capsule. So try to perform as much as hydrodissection as possible, but very gentle, because and make sure you are under the capsule, because if you are over the capsule you may damage the already weak zonules in uveitic eyes. All the intraocular structures in uveitis are very fragile and weak, so you should be very gentle during the surgery. So now I would like to perform phacoemulsification with low power and low vacuum settings. Very slowly and gently you should perform phacoemulsification. Try to grab the nucleus. I am trying to grab the nucleus and try to rotate the nucleus, but as I told you that complicated cataracts are very resistant, and we are unable to, but still slowly and gradually I am, because I cannot apply too much force here. So I am trying to take small chunks of nucleus. Now the nucleus and the cortex, they were tightly adherent to the capsule, so I came out, put viscoelastic, and with the help of a dialer I tried to separate the nucleus and cortex from the capsule, and now still the capsule is inseparable from the rest of the nucleus, and there is the resistance, and the zonules are also weak. So it seems that it's a very difficult phacoemulsification case. So I came out, and again I put some viscoelastic, and now I am taking another work from the iris hooks. Now I am putting the iris hooks into the anterior capsule to give the bag support, another layer of support. You can use these iris hooks to support the bag. So you can clearly see that at 3 o'clock and now at 9 o'clock I have released the iris hooks from the iris, and now I have engaged the anterior capsule in it, and now I have given support at 3 and 9 o'clock to the bag. So now I can perform. It has got two effects. One, that now there is a larger capsulorhexis due to traction of the iris hooks, and the bag is now stable, so I can apply a bit force, and there will be less damage to the zonules. So again I started phacoemulsification from where I left. You should apply all the maneuvers which you know, but you have to keep two things in mind, that you have to save the posterior capsule, you have to save the zonules, and you should also be away from the corneal endothelium. So these are the things in every phacoemulsification you should keep in mind. So now you can see that we have performed phacoemulsification, and almost we have removed the nucleus, and now there are dense cortical sheets which are also tightly adherent to the capsule, but we have removed those as well. You can see again I am rotating these sheets with the help of a dialer. With rotation they also separate from the capsule. So it was a very challenging case, and it took me in a real time it took me almost 35 minutes. A routine phacoemulsification I perform from incision to hydration 5 minutes, but it took almost 5 phaco time, but the end result was good. So now you can see that these dense sheets were also removed with phaco aspiration mode. Now with the IA cannula I am removing the remaining cortical sheets. You can see that still the two iris hooks they have engaged the anterior capsule at 3 and 9 o'clock, because it will also help in removing those deep cortical sheets hidden in the equatorial region. Try to remove all the cortical sheets, because in uveitic eyes, if you leave the lens matter, the inflammation is more intense than routine eyes. Take your time, don't be in a hurry, but the end result should be good. So now we have removed almost all the cortical sheets. So now I am removing the iris hooks. So in this video you have seen that in a uveitic severely constricted eye pupils, you should first remove the posterior synex, and sometimes when you remove those adhesions, the pupil fully dilates. But in this case, as it was a very old chronic uveitis, so even when we removed the adhesions between the iris lens and the membrane, still the pupil was constricted. So we used these iris hooks. So you have seen how I applied those iris retractors, and now how, and then you have also seen in this video that I have taken a dual action from these iris retractors. I stabilized the bag with it as well, and now I have removed all these, and now I'll put foldable intraocular lens. Now you can see that pupil is also bit dilated. Try to implant hydrophobic acrylic lens in uveitic eyes. And you can if the nules are too much weak, you can also apply CTR. So that was a case which I thought I should share with my viewers. I hope you have liked it. Do give your feedback in the comments section, and your suggestions regarding such cases and your experience. Thank you very much.